Thank you, Soha. Good afternoon, everyone. So we are going to have a talk about multimodality imaging of the tricuspid valve, and we will be focusing on normal appearance and some pathological entities. So, tricuspid valve, although historically overlooked, is no longer the forgotten valve. Tricuspid valve is now recognized as critical determinant of patient survival because severe tricuspid regurgitation is now considered as a strong predictor of patient survival and prognosis. And also the rapid rise of transcatheter tricuspid valve intervention has transformed the right heart from a passive bystander into a critical target of therapy. And why multimodality imaging? Because multimodality imaging can complement the role of echocardiography with many advantages like accurate quantification of the severity of valve lesion, accurate assessment of ventricular anatomy and function, or what we call the adverse hemodynamic effects of valve lesion, and also multiparametric comprehensive assessment for myocardial scarring and inflammation. And these are the toolkits for tricuspid valve assessment. Of course, echocardiography will be the first line tool for the assessment, and advanced imaging may be required if advanced quantitative measures or procedural planning, for example, is indicated in certain patients. So what's the tricuspid valve structure? The tricuspid valve is the largest cardiac orifice. Its area is about 7 to 9 centimeters square, and like mitral valve annulus, the annulus of the tricuspid valve is saddle-shaped and unplanar. And classically, tricuspid valve has 3 leaflets, which are the septal, anterior, and posterior leaflets. As we can see, this is a surgical view. The aorta is located at 12 o'clock. This is the interatrial septum, anterior mitral leaflet, and posterior mitral leaflet. And this is a tricuspid valve here. Medially is a septal leaflet, anterior and posterior leaflet. This is the classic structure of the tricuspid valve, and this is by 3D transthoracic echocardiography. As we can see, this is from the RV perspective. Again, this is the interatrial septum, making this the septal leaflet, anterior leaflet, and posterior. Usually the septal leaflet is attached to the fibrous trigone, so it's the least mobile leaflet among the 3. The largest one will be the anterior leaflet, and the smallest or shortest one will be the posterior leaflet. This is by rotating the volume from the RA perspective. I think the pointer is not working, so I'm going to activate the laser pointer here. So this is from the right atrial perspective. As we can see, again, this is the interatrial septum, septal leaflet, anterior and posterior leaflet. So now, who said that tricuspid valve is a tricuspid valve? Actually, the tricuspid valve is only tricuspid in 50% of patients. This is surprisingly, right? Because tricuspid valve can take different morphologies or variants. The most common one, about 50%, will be the tricuspid valve, but the tricuspid valve can be bicuspid in about 5% of cases, with typical fusion of the anterior and posterior leaflets. So this is a septal, and this is a fused anterior and posterior leaflet. This is a bicuspid valve. Or more commonly can be quadricuspid valve with a supernumerary leaflet, as we can see here, making the septal, anterior, posterior, and another 4th leaflet. And this is about 40% of cases has a quadricuspid tricuspid valve, and the last type will be more than 4 leaflets, and people have described up to 8 leaflets of the tricuspid valve. So, when assessing the tricuspid valve, we have to assess the right ventricle as well, because the tricuspid valve is mechanically and functionally linked to the right ventricle, or what we call the valve-ventricular complex. And the problem is RV has complex 3D shape with 3 components: the inlet part, muscular part, and outlet part. The 3 components are wrapping around the left ventricle, as we can see here. So we have many limitations in the assessment of the RV by 2D echocardiography. Usually 2D measures only the inlet and the muscular part, not the outlet part of the right ventricle. And here comes the role of 3D modality imaging, as we will see. So different tricuspid valve pathologies will include tricuspid valve regurgitation, stenosis. We will talk about assessment of the right heart, some congenital heart disease, and finally a small hint on percutaneous interventions. And first, with tricuspid valve regurgitation, according to the guidelines, we have to assess the severity of tricuspid regurgitation, as we can see. But first, we have to look at the leaflet morphology. What is the mechanism of tricuspid regurgitation? So as we can see here, these are 3 different patients. This is a normal appearance of the tricuspid valve in the RV inflow view. This is a patient with thickened doomed tricuspid valve leaflets, traumatic affection of the tricuspid valve. This is another patient with flail tricuspid valve leaflet, right? But which leaflet is this? This is the anterior leaflet, posterior leaflet, or maybe septal leaflet? Who knows? Actually, for the assessment of the tricuspid valve leaflets by 2D echo, we have to obtain multiple views, at least 3 views, which are the RV inflow view, the parasternal short axis view, and the apical Fourier chamber view. Because in the RV inflow view, as we can see here, it's moving from the parasternal long axis view, and we are tilting the probe down or inferiorly to get the RV inflow view. So the first leaflets of the tricuspid valve we're going to cut are the anterior and septal leaflet, right? So this might be anterior and septal leaflet, but going more tilting inferiorly, we will be cutting the anterior and posterior leaflet. So in the RV inflow view, this is the anterior leaflet, and the other one might be septal, might be posterior. The hallmark here is the coronary sinus. If I'm still seeing the coronary sinus, then I'm still medially. So this will be the septal leaflet. If I tilt more inferior to get rid of the coronary sinus, this will be the posterior one. Moving to the apical Fourier chamber view. Again, in the apical Fourier chamber view, I am cutting the tricuspid valve along this direction here. If I am looking a little bit superiorly, I am obtaining the LVOT. This will be the anterior and septal leaflet here. This is the LVOT here, anterior and septal leaflet. But if I look down, I'm getting again the coronary sinus. This will be the anterior and, sorry, the septal and posterior leaflet. So this will be the septal leaflet and posterior. But if I'm getting a proper Fourier chamber view, it might be anterior or posterior. So in the Fourier chamber, it's always septal, but the other one might be anterior, might be posterior, according to my cutting plane. The same for the parasternal short axis view, and we'll be cutting the tricuspid valve along this direction here, and I might be getting the whole length of the anterior leaflet, as we can see, or looking more down, I'm cutting the anterior and posterior leaflet, or more and more down, I'm cutting the anterior and septal leaflets. So it's a long way to assess the tricuspid valve leaflets by 2D, but if you have the privilege of 3D echo, you can obtain a 3D zoom mode across the tricuspid valve, putting it anatomically, and then start to assess the leaflets. As we can see, again, this is from the right atrial perspective. We can clearly see here the prolapse affecting the septal leaflet of the tricuspid valve. Another patient with flail anterior leaflet, as we can see here also from the right atrial perspective. And this is a patient from the RV perspective. We can clearly see the marked tethering and restricted mobility of all the 3 valve leaflets. This is a patient with carcinoid disease. Then going for the estimation of severity of tricuspid regurgitation, we are not going to take much time in it. We have a semi-quantitative and quantitative measures according to the guidelines, the vena contracta, the hepatic flow reversal, or measurement of the PISA radius and VTI to get the arrow and regurgitant volume. If the effective regurgitant orifice area is more than 0.4 centimeter square or the regurgitant volume is more than 45 milliliter, this is severe tricuspid regurgitation. But we also have that we have many limitations in the 2D echocardiography for estimation of the PISA, because PISA basically assumes that the regurgitant orifice is circular, but it's not always circular. It might be oval or oblong in shape, as you can see here. So the best way or the most accurate way to obtain the regurgitant orifice area is by, again, acquisition of 3D mode across the tricuspid valve, colored mode this time, then getting it to the MPR mode to plan across the tricuspid valve orifices in 2 orthogonal planes to get the true on-phase view of the regurgitant orifice, and then direct planimetry of this area here. This is the 3D vena contracta area. If it's more than 0.75 centimeter square, this is severe tricuspid regurgitation. And now, moving beyond primary and secondary TR, we have to classify the tricuspid regurgitation, either whether it's primary TR or functional. And functional, we have atrial function, ventricular function, or cardiac device-related tricuspid regurgitation. As we can see, these are examples of primary tricuspid regurgitation with prolapse affecting the 3 tricuspid valve leaflets, as we can see here. This is another patient. Remember, this patient with flail anterior leaflet, as we can see. This is the septum here, anterior and posterior. Flail anterior leaflet with a large hole or non-coaptation defect inside the heart. Again, this is a patient with rheumatic tricuspid valve. This is another patient with marked restriction of the septal and posterior leaflet and only mobile anterior leaflet with large non-coaptation defect. All these are examples of primary tricuspid regurgitation, and also patient with infective endocarditis, multiple masses attached to the atrial aspect of the tricuspid valves. This is also a primary TR. While in this example, the RV is markedly dilated and impaired function with marked restriction and tethering of the tricuspid valve leaflets with also pseudoprolapse, making it functional ventricular tricuspid regurgitation. Another patient with markedly dilated and impaired right atrial function with dilated annulus and large non-coaptation defect, making it atrial functional tricuspid regurgitation. And finally, obviously, this is a cardiac device-related tricuspid regurgitation. So do we have a rule for transesophageal echo in tricuspid valve? Actually, it's a very limited rule because the tricuspid valve is the most distant from the transesophageal probe, but we can use transesophageal echo in selected cases, like cases with cardiac device related or patients with biprosthetic valves, for example, if we are going to assess. This is an example of a patient with pacemaker, and we can appreciate these multiple small mobile masses attached to the lead. These are probably multiple thrombi or tiny thrombi attached to the lead. Another patient with multiple highly mobile vegetations attached to the lead on the right atrium and also at the entrance of the lead from the SVC to the right atrium in a feverish patient, a patient that has infective endocarditis. And this is a patient with biprosthetic tricuspid valve. We can also assess the stenosis and transvalvular or paravalvular regurgitation, and we can also use 3D transesophageal echo in planning for percutaneous interventions. Now, for the sake of time, we are not going to talk about tricuspid valve stenosis, relatively uncommon scenario, but we have multiple etiologies like rheumatic carcinoid or obstruction by masses or vegetations, as we can see here in this patient with carcinoid disease. So when assessing tricuspid valve, we must not assess the tricuspid valve in isolation. We have to assess the right heart function because there is a paradigm shift from diagnosis to prognosis. And according to the 2025 AAC guidelines for the assessment of right heart, it put a binary cut, change it from binary cutoff, which is normal or abnormal, to graded severity. You have to grade the RV impairment from mild, moderate, or severe because it carries an important prognostic factor. And we have 3 pillars for assessment: structure, function, and hemodynamics. The hemodynamics for the pulmonary artery pressure and the cutoffs for the tricuspid regurgitation peak velocity. If less than 2.8, this is normal. If more than 3.6, this is severely impaired. Also, as a structure for the assessment of the RV dimensions, RV wall thickness, right atrial size and right atrial volume, and also pulmonary artery diameter, and these are the cutoffs for normal and abnormal. Also, the right heart function for the TAPSE, S prime, and fraction area change, and these are the cutoffs here. But again, we have limitation in 2D echo assessment of the RV function, so if we have the privilege of 3D, we have to measure the RV ejection fraction by using 3D echo, because in 3D, as we can see here, it can measure the 3 compartments of the right ventricle, the inflow, the muscular, and the outflow part, and it gives us an accurate measurement of the end diastolic volume, end systolic volume, and ejection fraction. And these results by 3D echo are highly comparable to the gold standard for the assessment, which is CMR. And speaking of CMR, what is the role of CMR to complement the role of echo? Again, CMR allows for unrestricted imaging planes for valve anatomy and function, flow and velocity quantification, and of course, accurate measurement of ventricular volumes and function. So we have unrestricted imaging planes. We can image a tricuspid valve from any plane of interest we need. We are not limited to the echogenicity of the patient or certain planes. This is a 4-chamber view, RV2 chamber view, RV3 chamber view, and also short axis view of the tricuspid valve. And we can appreciate all tricuspid valve leaflets here. This is a septal leaflet, anterior and posterior leaflet, and this is a central non-coaptation defect for the tricuspid regurgitation. We can use the flow and velocity quantification for assessment of the flow across the tricuspid valve. This is the Doppler imaging of the MRI, which is a 2D phase contrast flow. We can appreciate the forward flow across the tricuspid valve and also the regurgitation, if any. And we can also use the 2D phase contrast flow to measure the flow across the pulmonic valve. And why is this important to measure the flow across the pulmonic valve in tricuspid valve disease or tricuspid regurgitation? We will get across this in a minute. So by tracing the contours of the pulmonic valve, the software can automatically detect each proton passing through the pulmonic valve in the forward direction. This is the forward flow, and in the backward direction, this is the backward flow or regurgent volume. And the subtraction between these are the stroke volume. Then MRI is the gold standard, of course, for ventricular volumes and function assessment or the adverse hemodynamic effects of the valve lesion, because we can obtain a stack across the ventricles, the LV and RV, from base through apex, and then putting it to software, and we can trace the endocontours and epicontours at the end diastolic and end systolic phases to get the end diastolic volume, end systolic volume, and accurate measurement of the RV ejection fraction. This is so important for patient prognosis. So back to quantification of the tricuspid regurgitation. How can we quantify the degree of TR by MRI? Usually by indirect method, by subtracting the total RV stroke volume from the pulmonic valve forward flow. And here comes the values of measuring the pulmonic valve in tricuspid regurgitation. It is RV stroke volume minus pulmonary valve forward flow, because basically I need just 2 more minutes if it's possible. I cannot see anyone from ICOM here. Sabona Umish. Yes, okay. So it is a total RV stroke volume minus pulmonary valve forward flow, because the RV stroke volume is the volume of the blood ejected from the ventricle with each cardiac cycle, and pulmonary arterial forward flow is the volume of the blood received from the pulmonary valve with each cardiac cycle. So the difference between both will be the tricuspid regurgitation. This is a basic equation for calculation of TR, and TR or quantification fraction will be the volume divided by the total RV stroke volume. So can we directly quantify tricuspid regurgitation by MRI? Yes, we can by advanced techniques like 4D flow CMR, where we can obtain anatomical images and we encode the flow in 3 directions, the anteroposterior, right, left, and feet head directions. So we can trace the tricuspid valve annulus, and software will track the annulus we're moving up and down during the cardiac cycle and detect each proton passing through the tricuspid valve to get the forward flow and backward flow. This is for direct quantification of the tricuspid regurgitation. Of course, CMR is a gold standard for assessment of myocardial fibrosis, which carries poor prognosis for the patient, like for example, this patient with transmural fibrosis across the RV lateral wall. CMR or cross-sectional imaging is particularly useful for patients with congenital heart disease, like Epstein anomaly. This is a patient with Epstein anomaly with extensive fibrosis, a patient with tricuspid atresia with membranous atresia and ASD, a patient with partial atrial ventricular septal defect and complete AVSD. This can be easily diagnosed by CMR. So why multi-slice CT? Because CT can assess calcifications, like this patient with extensive calcification, another patient with spot of calcification across the tricuspid valve with a central non-coaptation defect, as we can see here. And also it's the gold standard for procedure planning, and I'm sure we are having an excellent lecture from Victoria about tricuspid valve interventions. So in conclusion, tricuspid valve disease represents a major health problem that affect a wide proportion of heart failure patients. 3D echo is particularly important, and also cross-sectional imaging is particularly useful for complementation of the role of echocardiography. And thank you.
Thank you, Mahmoud.